Hi, everybody. This is Patricia Potter with Kirkland Solutions. This is our Intermacs and PDMacs user group webinar. Today is April 24th. Go ahead and get started here. So for today's agenda, I'm just going to go over some STS housekeeping agenda items, and then the majority of our call today will be a presentation by Rebecca Harrop of Northwestern. She's going to be doing part 2 of our new data manager webinar series. We had part 1 back in March. And then the end of our call will be an open discussion and just a reminder to use the Q&A function. We'll answer as many questions as we can. And we encourage your participation and feedback. We love hearing from you. So today from Kirkland Solutions on the call, we have Rama, John Pennington, Jeannie Ann Love, Brandon Singletary. And I think that's everybody from Kirkland Solutions. And then from STS, we have Carol, Bono, Emily, and then, and Leanne Jones. And, I'm sorry, I forgot Maceo. He's part of Kirkland Solutions. Sorry about that, Maceo. And then from Northwestern, we have Rebecca on. And like I said, she'll be doing our presentation today. And then just a couple of important dates to go over. Tomorrow, April 25th at 2 p.m. Central, we have the Intermacs PDMacs Quality Assurance webinar. So that will be a webinar presented from the reports teams. Dr. Ryan Cantor, he'll be doing that. So it's a great opportunity to come learn about the reports, ask any questions. He and his team will be on that call. And then I did just want to point out that April 30th is the data entry deadline for Intermacs and PDMacs for the Q1 reports. So that date is coming up. So just stay tuned for that. And then those reports will be distributed June 30th. And then AQO 2024 is going to be coming up in September. Registration is open for that. If you go to the STS website, sts.org, and you click on sorry, one second, I think it's resources. If you click on resources, then click on data managers, the first option there is all the information you need to know about AQO. The schedule is Wednesday, September 11th will be the Intermacs and PDMacs sessions. And the general thoracic will also be that same day, adult cardiac on the 12th, and congenital will be on the 13th. There's 2 options this year. There is an in-person pricing and a virtual pricing. And an early bird discount will be offered through May 16th. So if you go on to the STS website and click on AQO, all the information for AQO is on there. There's information about different packages if you wanted to go more than one day, multi-day, or single day. If you abstract data for multiple registries, there is options for that as well. AQO will be in Nashville, Tennessee this year, so there's information about the hotel room block and booking that. So all the information is there and registration is open and live. Anything you wanted to add to that, Emily, or did I kind of cover it?
The only other thing is if you need a registration form that if you can't register online and say your institution pays for registration or something, there's a form on the website as well that you can mail in with a check. That's about it.
Okay, thanks, Emily. And on tomorrow's webinar, I'll give a little more information on this as well. So just here's mine and Carol's contact information. If you have any questions anytime, feel free to reach out to us. We love hearing from you all. So Rebecca, I'm going to turn it over to you. So I will stop sharing now.
Sounds good. Thank you, Patricia. Okay. Everything's up and everybody can see the screen?
Looks
Yes,
good.
ma'am.
Yep.
Yes, ma'am.
Perfect. Well, thank you, STS, for having me. As Patricia said, my name is Rebecca Harrop, and I'm a VAD coordinator and the site administrator at Northwestern Memorial Hospital for STS Intermacs. And I am over the moon to be able to come and talk to you about this today. The new data manager session part 2. It really is just the next piece to what Patricia went over in March, which was how to really leverage the STS database, the Keros, not database, excuse me, websites to find the facts and the things that you need to help educate yourself a little bit about Intermacs itself. But what I'm going to talk about today is really the nuts and bolts. So getting these patients into the database itself. So we're going to be looking at understanding how to successfully enter a patient into the database. We're going to calculate and understand Intermacs follow-up windows. And I'd like to assess patient charts to be able to identify Intermacs adverse events. So it's a lot to get through. I want to make sure that we've got ample time for questions at the end. So I'll make sure to be cutting off with 10 to 15 minutes so we can kind of get through some of that. So please put them in the Q&A function. So with that, we have to start with the screening log. That's how we get a patient into Intermacs. We start with the implant date, and most of this webinar, the slides, you're going to have seen all of these screens because you've put a patient in. So we're really just going to be speaking to kind of the nuances of it. Inclusion criteria for Intermacs is pretty cut and dried. Is the VAD FDA approved? And was it implanted after March 1st of 2006? Exclusion criteria, the same. If they are receiving a non-FDA approved device, it may not go into Intermacs. And then if the patient is incarcerated or they're a prisoner. From there, it asks device type. And this is important because a patient either goes to the OR for a durable LVAD, a durable RVAD, both in the same OR, or a total artificial heart. And in this instance, I'd like to focus on the both because it can be an an LVAD that is durable and an RVAD that is temporary, or this could be a durable LVAD and RVAD, so a true BIVAD that's going to stay in. Once you've chosen what the patient received in the operating room, it's going to ask for a device brand. And for the adult side, Intermac side of things, really anymore, we're pretty much just putting in the HeartMate 3. So that's an easy one to pick for the LVAD most of the time. But for the RVAD, I want to point out that you really want to be looking for the rotor that's being used and not the cannula. So if the patient has an RVAD that's using a Protect Duo cannula, you won't find Protect Duo in this list, and you don't want to choose other and type in Protect Duo. You need to dig a little bit more into your charting and find out, is it a tandem heart that's running that ECMO or that RVAD? Is it a Rotaflow? Is it a Centromag? And also in this moment, as soon as we're screening the patient, we already start thinking about AEs, because if the patient received both the LVAD and a temporary RVAD in the operating room, they're immediately going to need an early right heart failure AE. Now, having said that, ECMO in the operating room does not count as an RVAD if it has an oxygenator. It'd be VV ECMO. But that still counts as early right heart failure. So whereas a RVAD will go in to Intermacs, the ECMO will not. From there, the demographics page opens, as you all know, and this is really very straightforward. This is all your PHI, patient name, date of birth, medical record number, gender, ethnicity, race. But there are a few questions at the very end of the form that I think are worth mentioning, and that's marital status, highest education level, and if they're working for income. And I personally find that I'm almost always finding this information in my social work notes. So that's a really good place to start. And then finally, it's going to ask if the patient's involved in an LVAD or a VAD-related study. So this is not a single center, a study that you're doing at your institution. That's like right now at Northwestern, we're doing a driveline infection study with VAD patients. That's not the study that it's talking about. These are more manufacturer-related studies. So if you think your site is participating in a study that may fit this bill, talk with your surgeons, talk with your cardiologist, and then always feel free to reach out to Intermacs to confirm that this is a study that does need to go on to the demographics form. So the next piece is a form that I've made myself, and I use it on every patient. And in the spirit of my 8-year-old daughter, we are implanting Taylor Swift today with a VAD. Her surgeon is Dr. Jones, and her implant date was March 1st of 2024. I write down her OR in and out time because that's important for almost all of the forms moving forward, for your implant form, your pre-implant form. And then I go ahead and go onto a date calculator just on Google, and I put in a subtract 60 days, and I write down my 60-day pre-implant date. And that's important because the vast majority of the pre-implant form, we don't look back any farther than 60 days pre-implant. So knowing that date, having it written out in front of you makes it so that you're not putting in data that actually doesn't belong. And you'll see this form again as I speak through the presentation today, because with the implant form, I use this quite a little bit as well. So as we move into the pre-implant form, as you all know, the first page of it is a beast. It takes a while to get through. You're really digging through that chart, but it gets you to the nuts and bolts of the patient. You kind of know their history, what it's all about. I like to think about the pre-implant form as either being past medical history or the data that's 60 days pre-implant and no farther back. And that's really how it's broken up. So this first page of the form is admission date, height and weight. It's going to calculate that BMI for you. Some of the stuff that we kind of want in there to see and kind of round out our table one, if you will. But then it goes into things like device strategy at the time of implant. At my center in particular, we're pretty black and white. They're either listed for transplant at the time of surgery and they're bridge to transplant, or they're not and they're destination therapy. If you are a center that does use the possible bridge to transplant, likely, moderate, unlikely, really make sure you're having good communication with your cardiologist and your surgeons to make sure that you're on the same page in terms of what you're abstracting. If you do choose bridge to transplant, it's going to always ask you for the list date of transplant and then the UNOS wait list ID, which I have to reach out to my transplant coordinators to get. From there, the next two questions, so time since cardiac diagnosis and cardiac hospitalization in the last 12 months, I first go to my H&P because hopefully some of that is there. If not, the next thing I do is go to my problem list, because if a good problem list is filled out when they were diagnosed with heart failure, there should be a date stamp on when that went in there. But as we all know, the best charting in the world doesn't always happen. So I'll just start scrolling back through the medical record and hitting some office visits. And at 2 years and 1 day, I pretty much stop, because if they've had heart failure since that time, we don't go back any farther than 2 years. So I click greater than 2 years and move on. Same bit with my 12-month hospitalization, scrolling back through if I can't find it in a note to see how many times they've been in. And then also make sure I'm counting the hospitalization for implant if it needs to be counted. If it's selective, they're coming in for a VAD, I don't count that. But if they came in for, volume overload, definitely that, and they're getting the VAD same admission, that definitely counts as a cardiac readmission. As we move along in this, we're still in the world of past medical history. So do they have a cardiac arrhythmia? And if so, it gives you a good list of both the atrial and the ventricular arrhythmias. But I want to point out mostly this abstractor variable of history of ICD discharge or history of sudden death. I think that's an important one to realize is there. And also realizing that history of a life vest shock would go here as well, even though the patient didn't have an ICD. The life vest would kind of be the surrogate for that. Current ICD in place, yes, no, and then what type they have. Is it a CRTD or is it the standalone devices? Primary cardiac diagnosis. I want to talk about this one a little bit because, as you know, there's quite a list of this, from cancer to a whole bunch of congenital diagnoses, all the dilated diagnoses, and then some of the restrictive chemo therapy is one. There's a ton that you can go through. I often find that my docs aren't terribly descriptive in terms of diagnosis. So I'll often pick dilated and other and type in non-ischemic cardiomyopathy because there really isn't a true charting of, was it viral? Was it alcoholic? Was it idiopathic? Was it genetic? So if I don't have that, I try and make it a little bit more generic. As we move along, we're looking at non-surgical and surgical cardiac interventions. So thinking for your non-surgical, your CardioMIMs, your TAVR, your PCI for those ischemic folks. This is also where if you had a patient that had a pacemaker or ICD or CRT in the past, and they don't have it anymore, you would mark that this was part of their history. But you don't want to double abstract from the current ICD device in place and this non-surgical cardiac intervention. It's one and they still have it, or they don't have it anymore and it goes into this piece. Then also your surgical intervention. So what open heart surgeries have they had? CABG, have they had a valve repaired? Have they had previous ECMO? Just trying to think back through that surgical H&P. And then of course we do ask the question about if they have a history of dialysis. So once we get past that part in the form, we really now start looking at the current hospitalization and then the 60 days post, or excuse me, the 60 days pre. The clinical events during the hospitalization, every single one of these that you click, you're going to get a question below asking whether that intervention was present at the time of the VAD implant. So if you put a feeding tube, it's going to say feeding tube present at the time of the durable MCS device implant, yes or no. Today, I picked ECMO as the example because I wanted to let you see the drop down of if you pick ECMO. It's going to ask for your approach to insertion. It's going to ask if it was VA or VV, where your inflow and outflow were, and then the total number of days on ECMO. This is all pre-operatively. Nothing here are you going to look at if the patient was still on ECMO post-operatively. Also, having said this, the way we use ECMO anymore, these patients have a lot of different configurations. They may start on VA and go to VAV and then end on VV. The way it's set up in Intermacs, you only need to document the ECMO configuration at the time that they go in for the VAD and or at the time that it was discontinued prior to VAD. And finally, on this first page, it's going to ask if this was the primary device for the patient. If you click yes, we know it's their first durable device. If you click no, then it's either an exchange or maybe they've had an explant and we're putting a VAD back in. That'd be terrible, but it does happen. I find that my Intermacs patient profile numbers are in my surgeon's note, either the consult note or pre-op note, or most often in my OR, my op note. If I can't find that in one of those three spots, I'm going to first reach out to my surgeon and ask what he or she thinks the number should be and ask them to addend a note. And if for some reason I don't have that, then I can look back through the documentation and discern what profile the patient was at the time of implant. One piece that I would like to point out though is if a patient came in for an elective VAD, you want to make sure that you are marking the profile number at the time just prior to admission. So if you had a patient who was resting symptoms of 4 at home, who was only on oral medicine, and they came in a couple days prior to surgery and had a right heart cath that looked not so great, and they started them on milrinone, you wouldn't want to call that patient a 3 because they weren't on inotropes just prior to admission. They would remain a 4. Okay. We made it through the first page. We can take a deep breath. We're ready to go. I want to now take a minute to go through a few things to remember for the majority of the rest of the pre-implant form. And then I'll go straight into the next form, which is the hemodynamics form. So first and foremost, all pre-implant forms should be collected closest to implant, but within 60 days of the implant for all of these subsequent pieces. No data from the OR should be used in the pre-implant form. And the only caveat to the 60 days is the quality of life and trail making data that needs to be within 30 days of implant. So just good things to kind of remember. From there, I go into that hemodynamics form and I actually work backwards on this form. So I first go and look to see if the patient had a right heart cath within 60 days pre-implant. If they did, I write those numbers down and then I go up to my general hemodynamics and I find the vital signs that were done during that right heart cath at the time of cardiac output and index that was reported. And I use those as my general hemodynamics. If my patient didn't have a right heart cath within 30 days or 60 days preoperatively, then I go into my flow sheets and look to see if they had a swan in the ICU prior to going to the OR. If that's true, then I would use the swan hemodynamics from the ICU prior to the patient entering surgery, and I'd use the vital signs associated with those swan hemodynamics for my general hemodynamics. And then from there, I head on to find my echo findings. Most important here, again, it needs to be within 60 days, and you may not use the intra-op TEE for these findings. Remember, it has to be outside of the operating room. Okay, the next form, super simple. Labs, pretty cut and dry. Everything has to be within 60 days of implant. There are two options on pretty much all of the labs. So that's either not done or unknown if you can't find the lab results. And I was always like, well, I don't know when to use the not done and the unknown. So kind of the definition we want to use is not done should be used if the lab was not drawn within 60 days of implant. Unknown should be used if the reported value is outside of the parameters or range or contains a non-numeric component, such as a greater than or less than sign. Care everywhere or outside lab results are acceptable as long as they fall within that 60 days of implant. And then there are two labs that I always think are just a little bit odd as we're looking through this and hard to discern. That is the lupus anticoagulant lab. You know, once that lab's drawn, if it's positive or negative, it's really never drawn again. There's not follow up on that usually. So if the lupus anticoagulant was positive, then you can mark it on the pre-implant form as yes, and then every subsequent form is yes. And if it was negative, you can mark it in pre-implant and every subsequent form is negative. If it wasn't drawn, you'd choose unknown because there is not a not done option for the lupus anticoagulant lab variable. And then also the heparin-induced thrombocytopenia lab. If you have a positive pre-implant, you'd mark positive. But at your next interval, if you had a negative on a repeat, you would mark negative. And within the Intermacs system, if the HIT lab is positive, you do not need an SRA to confirm it. If HIT's positive, it's positive during that window. If it's negative, it's negative. The medication form in the pre-implant, I like to think as in two camps. So one side, the left side of my screen, is really going to be any medications within 1 year. Have they had these medications or a drug in this class of medication within the last year? If they had it on the day of surgery, so if say they went to surgery a little bit later in the day and they did have some oral meds in the morning, then that's definitely currently using. But a lot of times these patients are going to surgery early in the morning. So I look the day before. If they had the drug the day before, that's currently using if they went to surgery early the next morning. If they've had the drug or they've taken the drug anytime between 1 year prior to implant and 2 days prior to the VAD, then I mark known previous use within the last year. And if I can't find the labs within the chart, it's a no. I almost never use unknown with this. And for this component of the pre-implant form, I use Epic. I'm assuming most on the call do. If you do use a different EMR, I'm sure you still have a search function within a meds tab where you can go back and look at date ranges. So simply just type the date ranges in and it should pull up every medication that the patient has had during that year. I will make note that sometimes the order is a PRN order, and if I see that, I don't just mark that they took it. I do click on that PRN order and look at the administration record. And if there was no administration, the drug may have been ordered, but it doesn't fit the bill to be given within the last year. Now, the right side of the screen goes back to all of your 60 days. So we're not looking back at 1 year for these meds. We're only looking, did they have Entresto in the last 60 days, nitric oxide or Flowland? Loop diuretics. And I'm going to call this one out in particular because if you click yes, it does not ask for the current dose. It asks for the dose prior to admission. So it's going to ask for that home dose. So you'll need to head back to your H&P or maybe a pharmacy note to look for that. Inotropes as an outpatient prior to admission. This goes right here. Metolazone. If the patient has had this and you click yes, it's going to ask you if it's been intermittent scheduling or if it's been on a scheduled regimen. When looking at your sildenafils and some of the drugs to decrease your pulmonary hypertension and right heart failure, we want to click yes for that. But if they're using the drug for erectile dysfunction, it doesn't go here. And then finally, your DOACs and your NOACs. Okay. Quality of life, pre and post in Intermacs. On the left side of the page here, this is a form that I made that I use at our facility. I just staple it to the top of the KCCQ and the EQ5D. And it can be pre or post, patient name, the date that it's being completed. I have either the patient or the coordinator mark who is filling this out so that I can properly answer this question in Intermacs. There's a place for the 15 feet gait speed in seconds and the 6-minute walk test. And if the patient does decline either the quality of life forms or the walk, I ask the person administering it or approaching the patient to not only initial, but to circle why they didn't want to do it so that I can choose the appropriate drop down within Intermacs when I click no, that they did not complete the forms. Quality of life forms are super easy to find with in the Intermacs website. You can get all of the KCCQ forms printed off or downloaded right from the website itself, both pre and post in both English and Spanish. The EQ5D, though, we do have to email Intermacs for because of licensure, they can't be put on the website. So make sure if you need a copy of those in English or Spanish that you're reaching out to the Intermacs team. And then another, I think, important piece to talk about in terms of the quality of life paperwork is you need to keep it. So either a hard copy, if you keep a shadow binder on the patient, you can keep the actual paper forms. Personally, we scan into the medical records so we can recycle all the paper forms and have less chance of losing them. And then I know there are some lucky institutions that have this built into Epic, and the patients complete the quality of life forms on an iPad, so it's automatically uploaded. But you want this for quality of, not only for quality of life so you can look back and enter things, but for auditing purposes if you're ever audited by Intermacs. Also, as you all know, there's an exercise function component of the pre-implant form. This is where your 6-minute walk and your gait speed is going to go. If you've had a CPET, if the patient's had a CPET within the 60 days prior to implant, it goes here as well. And this form is actually where you upload your trail making and the time it took them to do their trail making as well. Okay, the last form to discuss, and you'll notice it's out of order, but of the pre-implant is the comorbidities form. I did not choose to go through every component of this because that could be a webinar in and of itself. But I wanted to pick 5 that I thought were important. First and foremost, severe diabetes. If a patient has a hemoglobin A1C of greater than 8 at the time of pre-implant, go ahead and click yes. And or if they have any issues associated with their diabetes, if they have neuropathy, retinopathy, you go ahead and click this as yes. If the patient has an A1C only of greater than 8 and no complications from their diabetes, you may not abstract this in a follow-up form as yes if their A1C drops below 8. So just realize this could be a yes or no abstracted differently depending on which form you're looking at. Prior sternotomy, we'll probably get a lot of questions about this one, but prior sternotomy is, did the patient have open heart surgery of any kind? Did we cut through their breastbone prior to their VAD implant? And this can be a hemisternotomy, so a portion of the breastbone cut, or a full sternotomy. And if yes, how many times? Usually for my congenital patients, sometimes it's a little tricky because their first sternotomy may have been like day 4 of life. So if you really don't know the count, unknown is fine. But for most patients, you're going to know. You do not want to cut or count your VAD implant done via hemisternotomy and thoracotomy or a full sternotomy in a prior sternotomy in subsequent forms. So if a patient had a CABG years ago and you put one prior sternotomy in the pre-implant and they had a redo sternotomy for their VAD implant, in all subsequent forms, you will only put one sternotomy. The only time that ever changes is if the patient has a VAD exchange, and then you would not only count the prior sternotomy that was before the primary VAD implant, but then you would go ahead and count the sternotomy from the primary VAD implant as well. So it would go from 1 to 2 at the time of that exchange. But you would not count the sternotomy or hemisternotomy from the exchange procedure. So we'll see. Hopefully I explained that well. In terms of your chronic lung disease, you're going to go to your PFTs. They need to be within a 12-month period prior to surgery. You don't want to look back any farther than that. Look at your FEV1, and if it's greater than 75%, the answer is no. If it's 75% or less, go ahead and follow the mild, moderate, severe definitions by Intermacs. And then on subsequent forms, this may change. If they have different PFTs and they're better or worse after VAD, this may not always stay the same. You want to be using your most recent PFTs. Same thing with pulmonary hypertension. You're looking at your pre-op right heart catheterization for a mean pulmonary pressure of greater than 25, or you may be using your echo data. But if they meet this criteria, the answer is yes. But on subsequent forms, if they come back and have another right heart cath and with the VAD unloading them, they don't have pulmonary hypertension anymore, then the answer is no. So realizing that these are all, they're living, they can change, they're fluid. And then finally, psychosocial issues. In particular, I wanted to pull out alcohol abuse and the history of smoking because there are drop downs with this. And you'll need to choose between remote or recent, which is either more than 3 months that they've been abstinent or less than 3 months. Okay, we made it through the pre-implant form. We're back to our initial hospitalization worksheet. And this is when I really head into the chart and look for my cardiopulmonary bypass time, my anesthesia induction time, my incision time. And as I'm doing all of this, if I'm seeing any AEs, I'm kind of making some notes for myself. And from there, I'm going to head straight into my implant form. We're going to quickly go through the top of this because this is going to be mostly from your OR documentation and from your surgeon's op note. The only differences to that are the associated findings component here, which is going to be from your interop TEE. And then your cardiopulmonary bypass time is probably going to be from your perfusion record. Place for your concomitant surgery, and then if the incision was closed or open at the end of the procedure. Again, the rest of the implant form, you're really looking 2 places. The left-hand side being from the surgeon's op note. Did they find a clot when they cored the ventricle? Was there a patent PFO that they saw as they were doing the surgery? Did they use the sewing ring that's provided by the manufacturer? And then how did they de-air the pump prior to turning everything on? The right side of the screen here is mostly going to be from your anesthesia note. So I will note here that for your hemodynamics, the reason why I write down those inductions and incision times is because I need that. All of these hemodynamics should be from the start following induction of anesthesia, but prior to skin incision. So I personally always use 1 minute before skin incision for my vital signs. And then your anesthesia note is also going to be where you find all of your blood products that were administered during the operating the OR, and then also the drug. So if they gave factor 7, if they gave a PCC. The one piece that I do want to speak to a little bit is over here where the LVAD procedure was complicated by vasoplegia during or after cardiopulmonary bypass. That's the main reason I write down the cardiopulmonary bypass time. I then go to my anesthesia note and I look at that time and I look to see when, if ever, the patient was on 2 vasoactive drips. And at that time, I'll then go back in to my anesthesia vital signs and I'll look for a map that's less than 60. And if I find a couple, then I'll click yes on this. The unexpected ECMO is a little bit easier to tease out than these the lower map and the greater than 1 vasopressor. Once you sign that implant form, everything's going to open up for you. Your 1 week's going to open up if you've taken a little bit to get your patient in. Your 1 month may even open, and your implant discharge is going to open up. So you're going to see all these forms start to populate. The 1 week and the 1 month form are exactly the same, and they are limited variables compared to all the subsequent forms. One piece that I do want to mention is the 1 week form. You want to use all time from when the patient leaves the operating room and arrives in the ICU until the follow-up date that you have chosen that's within the 1 week window. And then the 1 month is from the day after the 1 week follow-up state all the way to the date that you're using for your 1 month follow-up. Your implant discharge form. This is where you're going to say, was the patient alive and left the hospital? Did they unfortunately expire during implant hospital or index hospitalization? And where did they discharge to? So I have this patient going to a rehabilitation facility. I have a date of discharge. This could also be a date of LVAD exchange if you did have an exchange during index hospitalization. Then it's going to ask you for your length of stay. And I think there's 2 important pieces to call out here. One being that with Intermacs, we do not count post-op day 0. We count starting post-op day 1 through the day of discharge. Intermacs will calculate this for you. So if you put in that they had 5 days of acute ICU care, and then I put in 15 days of step-down care, well, the patient was only there for 17 days, calculated between the implant date and the date that I put for discharge. And it will give you a little error message saying that it can't exceed 17 days. So then I can go back in and double check myself. This is also where we're going to put any interventions during the index hospitalization. Did they go back for bleeding? Did they have a bronchoscopy? Did we remove ECMO, decannulate ECMO? And then this is also a new feature or a new variable, but was ECMO initiated at any time after VAD implant? If you answer yes, we only want the ECMO from the time of VAD to the time of discharge. We do not want any of our pre-VAD ECMO. And then for anyone on the call who does use a Berlin heart or a total artificial heart, this is where it's going to ask you about your console changes. Okay. I know we're kind of flying through this, but follow-up forms. The 3-month form, the 6-month form, and every 6 months thereafter that the patient is on VAD therapy, the form will look exactly the same. I have a screenshot of it here for you. You'll be abstracting the exact same variables, just the month or year for the follow-up. The title will change at the top. Determining your window is super important because if you're missing days within the window, you could be missing AEs or labs or things that we're looking at to capture in Intermacs. So I pulled from a patient that didn't have any readmissions between their 1.5 year and their 2.5 year to look at an example on this. And so looking at the 2-year follow-up, I need to look back all the way to the day after my 1.5 year follow-up. So my window would be from 1/10/2023 until the follow-up date that I'm using for my 2-year, which is June 26th of 2023. So that's a big window. To give another example, we'll look at the 2.5 year follow-up. We would be looking from June 27th of 2023 all the way to the date that I'm seeing this patient on December 20th of 2023. And I need to look at that entire time frame for AEs, readmissions. Did I miss a readmission? Were they readmitted at an outside hospital that I didn't know about? Did they go to urgent care? Do I need to look at my microbiology results to make sure that they didn't have something positive, and I need to dig back through to see if they received antibiotics and I have an infection AE? Those windows are going to define what you're looking for in terms of abstracting for this patient. So in each of the forms, 3 months and thereafter, there are these things that I'm calling non-triggered events. I don't know that Intermacs calls them that, but back in the day, they called these triggered events. So I figured non-triggered seemed appropriate. And that is, did the patient have a hemolysis AE during the window, a right heart failure AE during the window, or a neurological event during the window? So you need to go back through and look at the timeframes to look at all LDH and plasma-free hemoglobin during the window and see if they meet criteria for an AE for hemolysis. Similarly, you need to look to see if the patient was admitted during this window. If they were not admitted, they cannot have a right heart failure AE. But if they were, we need to make sure they didn't have ECMO or IV diuretics or IV inotropes for greater than 72 hours. If they did, then I at least need to go back and assess for right heart failure. And then finally, in terms of neurological dysfunction, if they've had a stroke or any sort of neurological event since implant, I need to go back and look for either a documented modified Rankin score, or I need to use my clinical judgment from the documentation available to determine a modified Rankin score. It does not have to be a neurology note that you use this from. You can use the heart failure note that you're looking at for the rest of your abstraction. Finally, on all the rest of the 3-month and subsequent forms, it's again going to ask you about your current device strategy. If you choose bridge to transplant, it will ask you to do the list of transplant states and the wait list ID as it did in the pre-implant. If you pick any other option for device strategy, a comorbidity form will populate that mirrors what was in the pre-implant form. Okay, I'm going to take the last couple of minutes to go through just a few AEs, and then we will open it up for questions. I really wanted to focus on the hemolysis AE because this is the perfect time to be using your search function within your EMR. You want to be looking back throughout the entire window. You need to see if they had a plasma-free hemoglobin of greater than 20 milligrams per deciliter. If they did, you meet definition. LDH is a little trickier though, because every hospital could have a different upper limit of the hospital's normal range. And you're looking at 2.5 times the upper limit of your hospital's normal range. So at my hospital, the normal range high is 271 units per liter. So I multiply that by 2.5, and I'm looking for any LDH that's greater than 677.5 units per liter. If I don't have that, I don't meet criteria. Also, if you have an isolated LDH elevation, just one, don't report that. But if you see a trend, 2 or more, it meets criteria. Once you know you meet criteria, then you have to determine if it's a minor hemolysis or major. Minor is the lab is weird. We know something's wrong because the lab is off, but we have no clinical symptoms. Major is we've got the lab that falls out of range, but we also are having either T-colored urine, anemia because the pump's chewing up their hemoglobin. We've got some liver enzymes out of whack, or we may be having a pump malfunction. Late right heart failure, I touched on this briefly, but we'll do it again. If they are not admitted during a window, they cannot have late right heart failure. Also, you cannot have you cannot have late right heart failure within 30 days of implant. So realizing that most patients are discharged from the hospital before 30 days. So you're not going to be ever picking this as a late right heart failure during your index hospitalization unless they have a hospitalization that lasts longer than 30 days. If the patient has been admitted, we've looked for IV diuretics and inotropes for greater than 72 hours, or if they were cannulated with ECMO, or if they had an RVAD, but that one's pretty cut and dry if they had an RVAD put in. If they meet the criteria for 72 hours of diuretics or inotropes, or they had ECMO, they also need to figure out, you also need to figure out if they had 2 of these clinical findings or 1 of the manifestations. If you can't find documentation of the 2 clinical findings or 1 of the manifestations, you still don't meet criteria. You must meet all components of the definition to meet the criteria. So it really does take a discerning eye and a little bit of time to get in there and you kind of devour that chart and find the pieces that you're looking for. Hepatic function, very similar to your LDH or hemolysis. You can start looking for hepatic function anytime after post-op day 14. You're looking for ALT, AST, and total bilirubin. That is 3 times the upper limit of your hospital normal. And I picked this patient in particular because their AST for my institution does meet criteria. Their ALT is uptrending, but does not meet. And their total Billy is uptrending but does not meet. So I might make a little note in my Excel file next to this patient to continue to watch for that I was close to a hepatic AE and make sure I'm continuing to look for that or keeping an eye out for that. Also, patients can have multiple instances of this. So if they have an hepatic AE, everything stabilizes and then they have a liver dysfunction again, it's okay to put in another AE. And lastly, arrhythmias. These can happen anytime after the patient leaves the OR. You have ventricular arrhythmias and supraventricular arrhythmias, and you're looking for, were they treated with a drug? Were they hospitalized for the arrhythmia? Were they defibrillated, cardioverted, which includes ATP for their ICD therapy, or did they have an ablation? What I will say is the AE can only be documented every 7 days. So if a patient had AFib RVR as soon as they landed in the ICU and they had it again on post-op day 3, you don't want to put that in again. But if they did on post-op day 8 have AFib with RVR, you can go ahead and put that in again. Now, having said that, if they have AFib one day and VTAC another, that excludes the 7-day. A different AE or a different arrhythmia restarts that. You just don't want more than one AFib AE within 7 days, and you wouldn't want more than one VT AE within 7 days. So I went through a lot. I thank you so much, and I will take questions.
Rebecca,
Great job,
thank
Rebecca.
you so
Thank
much.
you.
That was excellent. Fantastic. So I'll start going through the questions, Rebecca. It looks like we have some that have already come in. So if anybody else has anything they want to add, go ahead and you can put them in the Q&A function. So Rebecca, our first question is from Sarah. If we have marked VAD study on all of our patients that are participating in our internal review database study, do we need to go back and change all of those to no?
Okay. So I will be very transparent. I'm going to need Patricia for quite a few of the answers to these questions. My guess is that it probably should not have gone in. I don't know if Intermacs wants you to go back and change it. So Patricia, would you take that one, please?
Yes. Yeah, Sarah. So that's looking for like industry studies. So if it's just something that your own internal your own center is doing internally, that would be a no. So they're not like participating in an industry study. It's just something that you're doing on your own at your center. So those should be marked as no. Our next question from Tiandra. Hi, Tiandra. If a patient is on ECMO pre-implant and taken off prior to device implant, do you complete an AE for acute right heart failure? No. So for right heart failure or any of our AEs, we are looking at time post-implant. So you would capture the ECMO that the patient had ECMO pre-implant on the pre-implant form, but it would not be counted as acute right heart failure unless they met the criteria or definition post-implant. And then we've got, let me just answer these.
Another one from Tiandra, I think.
Time since first cardiac diagnosis. This section includes any known cardiac diagnosis like CAD, MI, cardiomyopathy. Yeah, that's correct. It's not specific for heart failure. It's any cardiac diagnoses. Patty, is there a manual that includes all the little nuances of answers, responses listed? I think that this question was related to when we were going over the pre-implant medications like known, what was it? Known previous usage in the past year, or yes, there is. We do have our user's guide, and within the user's guide, we do include FAQs that got updated about quarterly. And we are in the process of kind of making that user's guide more granular and have more clarification on those, on each of the data variables. So that will be coming, but we do have documentation out there. But Patty, if you ever have any questions, feel free to send me an email in the meantime. And then where in Epic does it say meds within 1 year?
I will take that one. I will share my screen again really quickly. Hopefully you can see it, but it's kind of hidden here under the known previous use within the past year. It will then say down below, if patients are known to have received these agents within the past year, please check known previous use. So hopefully you can see that up here under the pre-implant component.
Yeah, and we do, Patty, and just to kind of go back to you for those little nuances you were talking about, we do have the user's guide, but we also do, like Rebecca just pointed out, have helper text within the form to help you as you're answering the questions. And then from Tiandra, the FAQ for lupus anticoagulant and HIT states the following user question: lupus antibody and HIT, once positive, are they always positive? And the answer is yes. The first time it is positive, it is always positive from then on. In the case of a false positive, once it is known that is false, check no at that visit. So that's right. So like Rebecca had said, lupus, once it's positive, it's always going to be positive. The only caveat is with the HIT. If they were to have a lab drawn after after they could come off of heparin, they can quite possibly and will most likely have a negative. So once you get a negative, that does not need to continue to be positive once you get a negative. Why have the meds be confusing? Allopurinol to antiplatelet agent is in the last year, but Entresto is 60 days. Why not just keep as the same for the whole list? Sarah, it's just because when the forms were developed, the surgeons, they want to have more granularity on some of the medications for different analyses. So that's kind of why the questions are a little bit different for some of the medications, just for the granularity of it. Pre-implant medications for current using. I was told that was referred to day of implant, not any time frame prior to day of implant. Can someone clarify that? Go ahead.
Oh, yeah. So a lot of patients go to the operating room really early. So they're in PO, so they don't have any medications that day, right? But they did take their medications the day before. So that's your last source of truth, as it were. Otherwise, you'd always be picking known previous use for within the past year for everything.
Exactly. The next question, what if FEV1 is 76, but it shows moderate restrictive disease? What do you document? So
Yeah, go ahead.
you can say what you were going to say, Rebecca, and then I'll let you know what I think.
But this was one that it took me a while to let loose of too, because right, your institution, your documentation, you think, okay. And I really had to wrap my mind around the fact of that, okay, yes, we're going to treat this patient clinically at our institution like they have a mild restrictive, but per my Intermacs definition, it does not meet criteria. So I have to document what the criteria is, or my benchmarking for the rest of Intermacs is all off.
Exactly. Yeah, I 100% agree, Rebecca. So for a 76, that is outside of the chronic lung disease classification scale that we're using. So best advice is to just follow the classifications that we have on the forms. On the comorbidities tab for potential barriers to heart transplant, are we only selecting the data elements that are listed on the selection committee note as to why the patient is not a transplant candidate? Or are we also selecting risk factors that the patient has, i.e. CKD stage, large BMI?
I will let Patricia tell me if I'm doing this correctly, but I am taking what is on the all of it. So what is on the selection committee, but also their past medical history, because a lot of times, especially, let's give an example. I have a patient who comes in and they stopped smoking cigarettes 3 days ago. My selection committee may just say substance abuse, must be abstinent for 3 months or whatever, but they need the VAD. But they do have a BMI of 45 or 50. They do have a history of CKD. So I still go ahead and make sure that everything that meets criteria is in that section.
That's correct. Yep. And from Carson, circling back to the beginning, when screening patients, if a patient had a temporary RVAD placed at the time for LVAD, are you double documenting the procedures at the time of LVAD? So, no. So on the pre-implant form, you would not capture it there because the patient didn't have it pre-implant. It was put in at the same time as the LVAD. So that would be the case when you would, your device type would be BIVAD, LVAD, and RVAD. And then once the RVAD was decannulated, taken out, you would then complete the explant form for the RVAD.
Yep.
And then from Linda, a patient had a sternotomy prior to LVAD implant. A patient had a sternotomy prior to LVAD implant on the 3-month follow-up. I continue to mark prior sternotomy question as 1. Is that correct? Yes,
Correct.
that's exactly correct. We're not counting the current ad. And could you explain exactly what an LVAD exchange is? Sure. So an LVAD exchange is, say your patient has a HeartMate 3 and you've entered that HeartMate 3 into the database. And then for many different reasons, patients may have what we call an LVAD exchange, meaning maybe the patient, their pump became thrombosed, or they've had just chronic infections, and the best is to just take out the device and put in a new one. They would be literally just exchanging number 1, HeartMate 3, for number 2, HeartMate 3. And the process of doing the exchange is you go in and you click create a new event, you click on the explant form, and then you would select explant for exchange. And then once that device is taken out of the database, you'll go back in and you'll click add new device, and then you will put in HeartMate 3, number 2. Pre-implant hemodynamics. We're selecting unknown or not done if the BP method was automatic versus manual correct, since the definition states should be determined from auscultation or arterial line. That's right. So the best measurement for these VAD patients is obviously an arterial line or obtaining a map via a Doppler. So yes, that's correct, Tandra. Do you have to do the quality of life on every follow-up after discharge? Yes. So
During
the
every
quality of
window,
life,
yep.
Yeah, the quality of life forms will be asked on every follow-up. Rebecca, it's 3 months, 6 months, and then forward, right? I don't think it's
Yep.
on the 1 week or the 1 month.
Nope, it's 3 months, 6 months, and every 6 months thereafter. Correct.
Minnie, can you provide a refresher on how to navigate when an oxygenator gets added to an RVAD to become VV ECMO? And also if the oxygenator gets removed off the VV ECMO to transition back to RVAD. So Minnie, this was one of the recent changes we've had it. And on our intermacs.curso.net website, under the Intermacs appendices, under Appendix S, there is a slideshow for these RVAD changes on there. But pretty much what the key takeaway to the change was once the oxygenator is taken off of an RVAD and an RVAD is functioning as an RVAD, it gets added into the database. At any time after that, the oxygenator is added back to transition back to ECMO, just ignore it. Just leave the RVAD as is. And then on the implant discharge form, and I believe the explant form, we ask how many days the patient may have been on ECMO. So it's no longer going back and forth and explanting and re-implanting devices. Let me know though if you have any more questions on that. The
Oh,
upper
interesting.
limit for plasma for hemoglobin is 30. I look for anything greater than 30.
Yep, that makes sense. Also correlate it with your LDH. You're probably going to see a rise in both. So, yeah, if it's not 20, then you could have somebody who's your assay for your hospital is just different than others.
Carol, I just wanted to note we are at time. Are we okay to keep going a few minutes over to get through these questions?
Yeah, yeah,
Okay.
absolutely, Patricia. And
Okay.
if Rebecca's able to stay on, that'd be great. I'll still be here. If anybody else needs to hop off, you can go ahead and hop off.
I'm available.
Very nice, yes. Okay, thanks. Thanks, Rebecca. Thanks, Patricia.
Yeah. So our next question for modified Rankin score for follow-up. If the CVA incident was in 2021, are we using current modified Rankin score, or is it asking what the MRS form 3 years ago where the patient had the stroke? Thank you. So we're looking at current. So you'll put the original on, and then what is the patient's score moving forward. So we're looking at the progression. All right, from Carson, when you are completing follow-ups, are you looking at historic patient history or just from the last follow-up? For example, frequent shocks, are you checking yes if the patient has ever been shocked more than 3 times within 24 hours, or are you looking if the patient has been shocked 3 times since last follow-up?
So I consider my comorbidity form basically a past medical history. So if I clicked that before, I click it again.
That's correct. Yeah. So so for Carson, so that's specifically for the comorbidities, but for things like medications, labs, hemodynamics, that's a little bit different. That's looking at just the time since last follow-up to current follow-up. So 2 different things. For the comorbidities, that's kind of like the patient's history, whereas the other forms are looking at medications, labs, hemodynamics, those are looking at time since last follow-up. And then from Sarah, the problem is that there was no description for this question in the beginning. If it says industry study, it would have been clearer. Is there a way to change this description so there are less questions? Yes, absolutely, Sarah. So we can put helper text on there, which I will make a note to talk with the team about possibly adding that. And we will also, as we're developing our more defined training manual, we will be sure to add that in there. So thank you for that feedback. Question for Intermacs. Can you add ICD implant to the pre-implant current hospitalizations interventions list? Well, that would be, so on the pre-implant form, we do ask, does the patient have an ICD? So that's where we're looking to capture it. Am I understanding that right, Rebecca?
That's where we are looking to capture it. It does in the descriptor though say current, right? I'm looking right now. Does it say current or history of? Let me check. Hold on.
I can look at too.
It says current ICD device in place. So that is where you would put the current ICD even if it was placed during index hospitalization. So if a patient came in and said, or came in 15 days ago, and on day 3, they got their ICD, but they got their VAD on day 15, they would have a current ICD in place. So that's where that would be covered.
Yes, and also on the prior cardiovascular interventions, non-surgical, it is asked if they have a prior medical history of ICD. So it is on there as well. And then regarding right heart failure events, do IV push diuretics for greater than 72 hours count or just continuous? No, IV push scheduled doses do count as well. It just
Yep.
needs to be in the form of IV.
Anything IV, drip or push, you're looking for.
If I had a patient that had a HeartMate 2, then years later came and had an exchange to a HeartMate 3, I did not document correctly. I explanted and completed and then added a new LVAD under same device. Can I go back and correct this and add the new HeartMate 3? Yeah, if you can send me an email, my email is patricia.potter@curso.net, and send me the patient ID. I can take a look at it. We may be able to easily add it there, or we can do a ticket if it's 2 separate patient IDs and we can combine them into one ID. So if you just send me an email with the details and the patient ID, no PHI, I'll take a look at it and we can certainly fix it.
Nope, no need to calculate the dose, Nancy. They either had it or, oh, I'm behind, aren't I? Sorry. Go ahead.
No, you're good. And then the next question is, if they are in at 3 months, do you need a new quality of life? Yeah, so there is quality of life forms at the 3-month follow-up visit. If a patient expires 7 days after device exchange, the mortality will go toward the newly implanted device event, correct? We have a physician who is inquiring about this. Yes. Well, the mortality, yes, would be.
The mortality would just go to the institution. It's not broken down by surgeon.
But the mortality would count towards that event.
Correct.
Yeah. Colette, if we're not answering that right, let us know if we didn't interpret that correctly. Doesn't it say on the top of the form for comorbidity on follow-up since last assessment? Yes, it does say that on the tops of all the forms, but comorbidities are looking at the history of the patient, you know.
We're hoping to remove that.
Yeah, yes, that is on our list to do. But yeah, we are looking at the history of the patient and what could potentially be inhibiting the patient's eligibility for transplant. Calculating dosage of loop if on LASIK strips. So Nancy, for this, normally, I think there might be some helper text on there. Just an average. Take an average of what the average dose was. Going back to comorbidities, the form states which comorbidities were present at the, yeah. Yes, we are going to change that. All right.
Oh, we made it.
Anybody else have any questions? We can stay on for a couple more minutes if there's any other questions.
Really great job, Patricia and Rebecca. Thank you so much.
Rebecca, thank you so
Awesome.
much.
Thank you.
That was
Thank
a
you.
great webinar. And just if anybody at your hospital wasn't able to join today, this has been recorded, and Rebecca's slides and the recording of the webinar will all be on the YouTube channel. So you can always have them go back and reference that if somebody would like to listen to it, or if you would like to go back and listen again. So thank you everybody for joining. And just to reiterate, we do have another webinar tomorrow. That one will be focusing on the Intermacs, PDMacs reports, and that will be with Dr. Cantor tomorrow, who's our lead statistician, and that will be at 2 p.m. Central tomorrow. And those are quarterly, so those aren't monthly. So if you have any reports, questions, that might be a good one to join. So thank you, everybody. Have a great afternoon. And thank you again, Rebecca.
Thank you for having me. It was
Yeah,
great.
thank you both so very much. Have a great rest of the day, everybody. Great
You
job.
too.